Welcome back to the symposium. This session is the COG SIOPEN Frontline studies, which is going to be presented to us today by Dr. Daniel Morgenstern, who is Director of New Agent and Innovative Therapy Program at the Hospital for Sick Children in Toronto. As I said before, if anybody has any questions during Dr. Morgenstern's talk, if they can put them in the Q&A chat box, which you'll find at the bottom of your screen, and we'll get through as many of them as we can in the time we've got available. So I will hand over at this point to Dr. Morgenstern to talk about frontline studies in COG and SIOPEN.
Many thanks, Nick. I'm just going to swap over to my slides. So I'm pretending to be at work, but actually I'm presenting from home. So apologies in advance if there's background noise, but hopefully you can hear me okay. So I want to talk about the current frontline studies for high-risk neuroblastoma, both in the Children's Oncology Group and in SIOPEN, and to give a flavor of essentially where we've come from and where we're going in treatment for high-risk neuroblastoma. These are my disclosures. So I think the first challenge is actually to define what is high-risk neuroblastoma. And there are a couple of groups of patients who we always define as having high-risk neuroblastoma. And by always, I mean that there's consistency within all of the cooperative groups that these patients should be treated as high risk. And these are patients who have metastatic disease and who are not infants, and patients with tumors that have MYC amplification. I've said most because there's a very rare chance of a small tumor that's localized having MYC amplification, and that would be more complicated. The reason this gets complicated, as I kind of try to highlight the complication down here with this table, is that there are also other groups of patients who we might consider as having high-risk disease, but we really need to get into the details of those patients and the biology of their disease to determine whether or not we should treat them as high-risk disease. And there's also a difference between how high-risk disease is defined between the Children's Oncology Group and SIOPEN for these relatively rare patients with localized tumors, but with unfavorable features under the microscope. And so in Europe, those patients are generally treated as intermediate risk, whilst in North America, they're typically treated as high risk. But the headline here should really be that overall, there is by and large consistency between the two groups and across the world as to how we define high risk neuroblastoma. I hope that most people on the call are familiar with what I'm talking about when I mention Children's Oncology Group and SIOPEN, but just in case not, I wanted to just highlight these two groups. So the Children's Oncology Group is based out of the US, but also includes Canada, where I'm talking from, and Australia and New Zealand. And it's really a very, very large collaborative group looking after all of the different childhood cancer diseases. And the neuroblastoma group is a committee within this overall larger structure. SIOPEN is based in Europe and actually literally based in Austria, but also has participating countries now from around the world, including Hong Kong, Australia, New Zealand as well. And this is a group really which is neuroblastoma specific, although increasingly as part of the larger SIOP Europe group, which manages all different types of childhood cancer. So there are, of course, other cooperative groups out there. The group in Germany has recently joined SIOPEN, as has the group in the Netherlands. There's a separate group in Japan, and there are many other groups around the world, but these are the two largest cooperative groups for upfront studies in neuroblastoma. So just to go back to the kind of basics of how we treat high-risk neuroblastoma, I put this slide up really to highlight the overall treatment for high-risk neuroblastoma within the Children's Oncology Group and within SIOPEN, so within these two large collaborative groups, is really very similar in its overall structure. And you can divide that either into 3 or into 5 bits, depending on how you like to divide things up. Essentially an induction phase, which comprises induction chemotherapy, so different chemotherapy agents, plus at some point surgery to take out the primary tumor. A consolidation phase, which typically includes some sort of high-dose chemotherapy and stem cell rescue that we'll talk about a little bit more later, and a radiotherapy component to the primary tumor site. And then a maintenance phase, which includes immunotherapy. And again, as we'll talk about, there's some differences in the immunotherapy between the two groups. But importantly, this overall structure of induction, consolidation, maintenance is the same across the COG studies and the SIOPEN studies, even though the details are different. So I just want to go into that a little bit more detail to talk about the different components of the treatment, and again, to talk about where we've come from and where we're going. So this graphic is just to talk about the induction chemotherapy that has most recently been tested in SIOPEN in Europe in the high-risk study, which recently closed about a year ago. And that was testing two different chemotherapy backbones, something called rapid COG, which is multiple blocks of chemotherapy, but is given in a rapid fashion. And that means that the chemotherapy is given every 10 days, that you don't wait for counts, you just keep giving the chemotherapy every 10 days. And actually the chemo is very cleverly designed to allow the chemo to be given safely every 10 days. And that was always the standard treatment in SIOPEN in Europe for a long while. And in the last study, it was compared against a different backbone called modified N7, which gave the chemotherapy in a different way, one which would be more familiar to those in North America, where you get a block of chemotherapy, you then wait for count recovery, it takes about 3 weeks, you then get another block of chemotherapy, and you get blocks of chemotherapy with a gap in between to wait for count recovery. And essentially the outcome of this study was that there was no great difference in the response rate. Both chemotherapies seemed equally effective, but this second one, this modified N7 as it's called, had more side effects, was more toxic for the patients. And so the conclusion of this study was that there was no benefit of using this, and that the rapid COG remained the standard treatment within Europe. In the next study in Europe, the next high-risk study, which is just getting underway at the moment, as I mentioned, the German group called GPOH has recently joined SIOPEN, and they've always used a slightly different combination of chemotherapy agents in induction. And so the question arises, is their chemotherapy combination more effective, or is it less effective, or is it the same, compared to what we've now established as the standard treatment in Europe, which is this rapid COG? And so the next high-risk study is going to compare this rapid COG induction, chemotherapy every 10 days, against what has always been the German group's induction chemotherapy, which has some differences in the actual chemotherapy, but also is one of these chemos that is given in blocks every 3 weeks. And obviously this study is just getting underway at the moment, so we don't know the answer yet to whether one of these will be more effective than the other. In North America, in the Children's Oncology group, rapid COG has not been used. And the group has really used this kind of model of blocks of chemotherapy with count recovery, and the blocks given every 3 weeks. I've just put this in a slightly different color. I didn't want to get into the details of exactly all the different chemotherapy drugs unless people are particularly interested in that. But the difference really here is that in North America now, we give 2 blocks of chemotherapy at the start with drugs called cyclophosphamide and topotecan, which are a little bit gentler, we think, than these ones later on. And that we think helps to reduce the overall toxicity of this and makes the treatment a little bit better tolerated at the start. And at the moment, we use 5 blocks of treatment. We used to use 6, but 5 blocks of treatment is now the standard. And this is now really remains kind of the standard upfront treatment for neuroblastoma in the Children's Oncology group. What we're asking in the current study in the COG is to say, well, if that chemotherapy works for most patients, but not all patients, is there something extra that we could do to improve the response rate to the induction chemotherapy? Is there something we could add to get more control over the disease? And what is being tested is the addition of MIBG targeted radioisotope therapy. And I know that there have been other talks, I think even earlier today, about targeted radiotherapy. So I'm not going to go through the details of this, but just to say that this is a way of giving radiotherapy as a medicine, with the idea that the molecular drug that we give, the MIBG, takes the radiotherapy to the sites of the neuroblastoma and helps to kill the neuroblastoma cells wherever they are in the body. And we know this treatment is very effective in relapse and refractory disease. It's one of the treatments that we've used for a long while, and it's not perfect, but certainly it does lead to responses in that setting. And the question really is, well, if we use this treatment earlier on, could we get better control of the disease, and could we reduce the risk of the disease coming back in the first place? And the answer to that is we just don't know. And so this study that's going on at the moment, called ANBL 1531, is testing if we add MIBG to the upfront treatment, will that improve the long-term outcome for these patients or not? And that study is ongoing at the moment. It's been open for the last couple of years. So this just says in written form what I've just mentioned, which is the 1531 study from the Children's Oncology Group, which is the current high-risk study for patients with MIBG-avid disease. Those patients whose disease does not have an ALK aberration will be randomized to receive MIBG treatment with a stem cell rescue after cycle 3 of induction, and then they will carry on with the standard treatment to complete all of the other components of high-risk therapy. So it's adding another type of treatment to what is already a very complicated treatment strategy. So turning to the next stage after induction chemotherapy, or even during induction chemotherapy, is surgery. And the thing I just wanted to highlight here is some differences in approach, that in Europe, in the SIOPEN protocol, surgery is generally done at the end of induction chemotherapy when all of those blocks of chemo have been completed and when we know where the disease is up to. Whereas in the Children's Oncology Group, it's always been felt that actually it's better to do surgery earlier rather than later. And so generally surgery is done in the middle of the induction chemo, normally after cycle 4, before we get to cycle 5. One of the big questions in high-risk neuroblastoma, especially when there's metastatic disease, which means that the disease has spread from the primary tumor, wherever that is in the tummy, for instance, to bones or bone marrow, is how important actually is it to remove that primary tumor? We know that it's impossible to ever remove absolutely all of the tumor, especially if there's metastatic disease. So does it really make sense? And so there's been quite a lot of work trying to answer this question. And this is just one recent paper that was published from Europe. And these curves are comparing patients with CME, which stands for complete macroscopic excision, which macroscopic means without using a microscope. So essentially where the surgeon feels that they've got all of the tumor out, versus incomplete macroscopic excision, which means that there was some tumor that was visible by the naked eye that was left in. And these different curves show different things. So the top one shows that the risk of relapse, so event-free survival, is lower in patients who had a complete excision than those who didn't. So the event-free survival is better. Similarly, the overall survival of patients is better if they had a macroscopic complete excision than if they didn't. And unsurprisingly, the rate at which the disease comes back, not overall, but comes back specifically in that site of primary tumor, the rate of it coming back is higher if the tumor was not completely resected than if it was completely resected, which makes sense. What I think we're still not sure about in these data is, does this really reflect the surgery itself, or could it be related to the underlying biology of the tumor? Because you could imagine that a tumor that was more aggressive biologically would be more infiltrating of local structures and therefore harder to resect. And so maybe the patients who are not able to have a complete resection are those who always had a more biologically aggressive tumor. Or alternatively, maybe the extent of the surgery does really matter regardless of the biology of the tumor. And I think that's one of the next questions that we need to address. So I then want to talk about high-dose chemotherapy, and I just want to spend a little while explaining this because it can be a little bit of a complicated and B, controversial topic. So this kind of word cloud I put on the left here is just to try and highlight one of the complications here is that we use a lot of different language for talking about similar things. So some people call this a bone marrow transplant, some people call it a stem cell transplant, an autologous transplant, high-dose chemotherapy, and just to explain what those words mean. So generally, if you have chemotherapy that affects your blood counts, we give the chemotherapy, the blood counts drop down, we wait a little bit, and the blood counts recover on their own, and then we give the next round of chemotherapy, the blood counts drop down, then they recover on their own, and then we give the next round of chemotherapy. That's what normally happens. But with high-dose chemotherapy, sometimes called myeloablative chemotherapy, just to give it yet another name, it affects the blood counts such that the blood counts drop down, and they then don't come back up again because we've affected the bone marrow so much that it's not able to recover on its own. And in order to then allow it to recover, we have to give back stem cells. And you can either give back the patient's own stem cells, which is what we do in neuroblastoma because it's safer, or in theory, you can give back another patient's stem cells, and that's what would then be called a bone marrow transplant, because one of the places to get those stem cells is from bone marrow. But that's not generally what we do in neuroblastoma. Most of the time in neuroblastoma, we have collected the patient's own stem cells, stored them in the freezer, and then after the high-dose chemotherapy, we give those stem cells back, and that then allows the bone marrow to recover and for the patient to recover from the treatment. So quite often this is called a bone marrow transplant, but technically it's not, because it's not somebody else's bone marrow that we're giving back, it's the patient's own stem cells. So one of the questions that I think is often asked is, how good is the evidence that this works? And I just want to be clear that I said that at the start of this talk that both the Children's Oncology Group and SIOPEN have a similar overall pattern of treatment for their patients with high-risk neuroblastoma, and that includes high-dose chemotherapy for all patients with high-risk disease. But some of you may be familiar with Memorial Sloan Kettering, which is a hospital in New York, and they have a different protocol from everyone else, and they do not feel that high-dose chemotherapy is effective. So there is a difference of opinion out there, which we can address in the Q&A. But I just want to explain why in SIOPEN and why in COG we think that there is still enough evidence for high-dose chemotherapy for it to be the right thing to do. So I'm not going to go through the detail, but a lot of this is historical data. So from studies that were done quite a long time ago, where we compared giving high-dose chemotherapy against either not giving any more treatment or against giving standard chemotherapy. So this is one of those studies where patients either got high-dose chemotherapy, which here is written as myeloablative therapy, or standard chemotherapy. And those studies showed that patients who got the high-dose chemotherapy had a better outcome. And these are the updated results from that study that I just showed you that were published in 2009, which compared getting high-dose chemotherapy, which now, just to confuse things, is now called BMT, against ongoing chemotherapy or continuing chemotherapy, CC. And so these curves show that the event-free survival, so the risk of recurrence, is lower, the event-free survival is better in patients who got the high-dose chemotherapy than patients who did not get the high-dose chemotherapy. So giving evidence that the high-dose chemotherapy reduces the risk of the disease coming back. The overall survival, which is the chance of surviving overall, of course, from the neuroblastoma, looks as though maybe it was better for the bone marrow transplant group, but actually there's not statistical significance difference here. So these are effectively the same. So this is evidence that high-dose chemotherapy helps. But crucially, all of these studies were done before we added immunotherapy into the protocol. And so one of the arguments is that maybe with the addition of immunotherapy, which obviously helps to improve the treatment for high-risk neuroblastoma, that maybe then we don't need the high-dose chemotherapy anymore. But the most recent studies have not really backed that up. So one of the most recent studies was done that I think most people are familiar with is the study from Europe, which compared two different chemotherapy regimens, busulfan and melphalan, or BuMel, and carboplatin, etoposide, and melphalan. And I don't want to go into the details to this other than to say the chemotherapy matters. So when we talk about high-dose chemotherapy, we often talk about it as just being a block of high-dose chemotherapy. But really what we're giving is more chemotherapy. And the actual details of it, specifically what those chemotherapy medicines are, really does appear to matter. And so these data that I'm showing here were the demonstration from Europe that the chemo combination of busulfan and melphalan appears better than the combination of carboplatin, etoposide, and melphalan, at least on the backbone of the European chemotherapy induction. So this study called AMBL 0532 is the most recent high-risk study conducted in North America by the Children's Oncology Group, and really I think provides the best and most recent evidence for the benefit of high-dose chemotherapy. This study essentially said, well, if we think that high-dose chemotherapy is beneficial, and in North America we've always used SEM, which is carboplatin, etoposide, and melphalan, what about if we give two high-dose chemotherapies back to back? So we give a high-dose chemotherapy called thiotepar and cyclophosphamide, allow the blood counts to recover, and then give another high-dose chemotherapy, again with stem cell to recover, and then give a slightly reduced dose of SEM. And so these results highlighted here show that if we look at the event-free survival, the event-free survival is significantly better for patients who got a tandem high-dose chemotherapy than those who got a single. So it really does appear that getting 2 is better than getting 1, which is not direct proof that getting 1 is better than not having it at all, but really suggests that this high-dose chemotherapy does have a benefit. And if we look just at the patients who had this treatment and then went on to get immunotherapy, you can see that this survival difference holds out, and that the patients who got the tandem high-dose chemotherapy had a much better long-term outcome in terms of risk of relapse and a better outcome in terms of survival than those who got 1 high-dose chemotherapy alone. So to me, this really provides evidence that if we intensify treatment further, we can improve outcomes, but also provides evidence, not directly, but indirectly, that high-dose chemotherapy does improve the outcome for patients with high-risk neuroblastoma. So in the next high-risk study, or rather the one that's going on now, excuse me, as I've mentioned, we're adding MIBG therapy to induction, but also asking a question in the high-dose chemotherapy setting, which is saying, well, how do we take into account this information that we've got from Europe, from the SIOPEN group, that maybe BuMel is better than SEM? And the answer is that there's going to be a randomization between the tandem, which is what I just showed you, and BuMel. So comparing the tandem, the North American standard, with single BuMel. And that will help us to get some extra information that maybe BuMel is so much better than SEM that it's as good as a tandem. And actually, you don't need the tandem, you just need different chemo. That study is ongoing. What's next in Europe? So as I mentioned, the high-risk 2 study is just getting underway. I've already mentioned the randomization in induction. And the European study is also doing a randomization of high-dose chemotherapy, and is actually asking a similar question to that which we've already been talking about, which is, if BuMel on its own is good, what about doing a tandem high-dose chemotherapy with BuMel as one of those? And so the way it's being done in Europe is to use thiatipa on its own, not thiatipa and cyclophosphamide, which is what we had in Children's Oncology Group, but thiatipa on its own, then stem cell rescue and blood count recovery, and then another high-dose chemotherapy with BuMel. And so the question is going to be, if we add to the treatment intensity by adding another round of high-dose chemotherapy, can we improve the outcome for patients in Europe in the same way as outcome was improved for patients in North America? So I just want to kind of highlight here that this really reflects how the 2 international groups are learning from each other's results. That the North American group, COG, has taken the information from the SIOPEN study saying that maybe BuMel is better than SEM, and has incorporated a BuMel question into the next high-risk study in COG. And similarly, the SIOPEN group has taken the data from COG suggesting that tandem high-dose chemotherapy is better than single, incorporating a question about tandem high-dose chemo into the next high-risk study in Europe. Radiotherapy, I just want to mention very briefly because I'm not an expert on it and just for the sake of time, but there are several questions that are being asked about this by both collaborative groups. One is to say, can we reduce the dose of radiotherapy for patients who don't have any disease left to see, who had complete resection of their tumor? And the flip side of that is to say, what about patients who do have residual tumor left? Should we, or can we, or does it help to increase the dose of radiotherapy? And the 2 cooperative groups are addressing both of those questions. And there's slightly different opinions at the moment as to what the answers to those questions are between the 2 groups. But we can talk about that more if people are interested. So then to turn to immunotherapy. So this, as everyone will know, has been one of the major advances in the treatment for high-risk neuroblastoma. And I'm not going to go back and present all of the data showing why we think this works, but really just to highlight the similarities and the differences between how this works in the 2 cooperative groups. So in SIOPEN, we're using a drug called dinutuximab beta, and that is given over 10 days now as a long-term infusion, which I've shown this as a big bar, a long infusion because it's felt that that reduces the toxicity, and is given in combination with cisretinoic acid, also known as Accutane, also known as isotretinoin. We love to have multiple names for exactly the same drugs just to make life complicated. In the COG, we're using an antibody called dinutuximab, which you can tell by the name is very similar to dinutuximab beta, because actually these are the same antibody, just grown in the lab in different cells. So they're slightly different when they come out of the cells, but going in, they're the same antibody. So they're very closely related. But the North American antibody, the dinutuximab, is given differently. It's given as a daily infusion rather than this long-term infusion. And it's given with a cytokine, so a medicine which is designed to boost the immune system, called GM-CSF. And also these patients get cisretinoic acid. And this just reflects another way in which North America has learned from the information from the European group, because as people may remember, the European group used to give a cytokine called IL-2 with the antibody to see whether the IL-2 helped to boost how well that antibody worked. And 2 different studies in Europe showed that that IL-2 did not help to improve how well the antibody worked. And so that information was taken on board by North America. And in North America, in the Children's Oncology Group, we used to give dinutuximab with GM-CSF and with IL-2, but we've now cut out the IL-2 because of the evidence from Europe that it doesn't seem to help and just causes extra side effects. So the European standard of no cytokines and no IL-2 has now been partly adopted in North America. We don't use any IL-2, but we're still using GM-CSF. And I'm just mentioning at the bottom here a pilot study which is coming, which is to say maybe we can add to this immunotherapy maintenance and add further chemotherapy in the maintenance setting to try and reduce the risk of the disease coming back. And so this pilot study is just getting underway now in COG, where patients will get immunotherapy, retinoic acid, plus extra chemotherapy at the end of all of their treatment to see if that can reduce the risk of the neuroblastoma coming back. A word about molecular selection. I think this has been discussed quite a lot already in other sessions, which is just to say that we have this target of ALK mutations or amplifications, and we have drugs available for this in those patients who have a tumor with ALK aberrations. So in the current high-risk study, we're adding crizotinib for those patients. And as you have heard in other meetings, both the European group and the North American group are about to amend their protocols to add lorlatinib, which is another ALK inhibitor, so that both groups will be asking a similar question: that does the addition of a targeted drug help to improve outcomes for these patients with ALK mutations? So in the last section of this talk, I just want to talk about what's coming next. I think the big thing that's coming next is that everyone is very intrigued by the apparent effectiveness of giving anti-GD2 antibodies together with chemotherapy, especially in patients who've got relapse or refractory disease. So one of the big successes in relapse refractory disease recently has been temozolomide irinotecan plus dinutuximab. And so that really raises the question that if chemotherapy and antibody together works so well in relapse disease, what about giving anti-GD2 immunotherapy early on at the very beginning for all patients with high-risk disease? And this has already been tested in a pilot study that was run by St. Jude's. And so we know that it appears to be safe. And it's now being thought about in both the SIOPEN group and the Children's Oncology group about how we could incorporate this into upfront treatment for patients on both of those studies, both the SIOPEN study and the Children's Oncology group. And so more pilot studies are planned because, of course, it's important that we make sure that this is safe and doesn't compromise our ability to give the chemotherapy that we know works, or at least works fairly well. And then, of course, we'll need to see, is it actually better? Is it more effective than giving the chemotherapy on its own? So there are a whole bunch of unanswered questions before what sounds on paper like a great idea can actually be put into practice. As I've mentioned, is it safe? Crucially, will it actually work? Will it improve response rates in induction? And then if it improves response rates, what does that mean in the long term? Does it mean that patients are able to survive longer and have a smaller chance of the disease coming back? If we're giving more antibody up front and at the beginning of treatment, what does that mean for giving antibody at the end of treatment? Does it still make sense to give anti-GD2 at the end as maintenance if we've already given anti-GD2 at the beginning? And an intriguing question is, if we're able to show that adding antibody to treatment at the beginning improves outcomes, can we eventually get to the point where we might be able to cut back on other parts of the treatment? We don't know the answers to these questions yet. Another thing that we are all thinking about is, at the moment, all patients with high-risk disease are generally treated in a similar way. And I just on this slide highlight different patients with completely different diseases, all of whom would be considered to have high-risk disease, from an infant with MYC amplified disease, to a 5-year-old with metastatic disease, to a teenager with localized tumor that's unfavorable, at least in North America, will be treated as high risk, to a patient with a MYC amplified tumor. And all of these patients are treated as high risk at the moment, but clearly there are differences in the disease in all these patients. It would be crazy to imagine that they were all exactly the same. And so one of the things that we're trying to work on is to think about, can we stratify, can we break down this larger group of patients with high-risk neuroblastoma into smaller groups? And there are several reasons why we might want to do that. So one is to say, can we identify patients who are not benefiting from our current treatment, who are going to relapse, who are not going to respond? And can we then do something else? One of the big difficult questions is, well, even if we can identify them, what actually else can we do? Because unfortunately, we don't have a lot of great treatments that we are holding back. We're doing everything we can, but can we think of something else that we could do for those patients who are not benefiting from the current therapy? Could we think about identifying patients who do really well with the current treatment? And do they maybe not need all of the complicated treatment that we're giving? Can we think about reducing the treatment for those patients? And finally, as we've already mentioned with the ALK, can we identify patients with a particular molecular target, and can we then add a targeted drug, or can we take those patients out and treat them differently? And so just to mention briefly, one way that we're trying to think about that is, can we do more sequencing of tumors up front? And if we do, how would we begin to incorporate that into the treatment decisions for patients? And this is a very complicated thing to do because A, we have to do the sequencing, B, we then have to identify potential targets, and then we have to see whether there's particular treatments for them, and we then have to work out, is that actually better than what we were doing before? But I just want to mention one group of aberrations that are, I think, likely to be very important, which is abnormalities in something called TERT, which is telomerase, or ALT, which is something quite complicated, but another way of lengthening telomeres. And this is all about how cells are able to cope with dividing and dividing and dividing and dividing and dividing. And it's becoming increasingly apparent that there are a group of patients with high-risk neuroblastoma who have abnormalities in this pathway, who appear to have particularly challenging disease. One of the problems at the moment is we don't really have great therapies for those patients. And so that's definitely an area we need to focus on. Yes, we could think about taking these patients out and identifying them, but what are we actually going to do differently to treat their disease? And so there's a lot of research going on at the moment to see how we might be able to add sequencing into all of the other factors that we take into account to work out how best to treat patients within the high-risk neuroblastoma group. So what are the big challenges? So I think there are several of them. I just want to highlight a few. So one of the big challenges is, if we can identify patients early on who are not going to respond to our current treatment, what else could we actually offer them? And that's one of the questions I think many of us are asking ourselves. I don't have a good answer for you at the moment. If we incorporate anti-GD2 antibody earlier into the treatment, safe, and what does that mean for the rest of our treatment? Can to reduce the treatment? And I think many of us would love to get to the point where we could begin to reduce treatment, because we know that our current therapy is extremely intensive, but I'm not sure that we're quite there yet. And of course, related to that is, how do we address late effects from therapy, and how can we improve those late effects? So those are the big challenges. And I want to just kind of end on the positive note of the successes. And the successes really I've tried to reflect in this picture, which I think the big successes are the learning from each of the cooperative groups from each other. We've not done one global study for high-risk neuroblastoma because I think it's at the moment too complicated to do and not necessary. But crucially, each of the cooperative groups has learned from what the other one has done. So as I've mentioned, the BuMel story has gone from Europe to COG. The COG tandem story has gone from COG to SIOPEN. The IL-2 story has gone from SIOPEN to COG. And so there's a lot of exchange of information between the two groups, which means that each group can ask its own questions, but those then contribute answers to what the other group needs to know as well. And by that mechanism, we're able to move things forward faster than we otherwise would be able to. So my last slide, what are the take-home messages? So the take-home messages are the overall treatment is similar between COG and SIOPEN. that increased treatment intensity does appear to improve outcomes for patients with high-risk disease. The international collaboration is definitely helping to improve therapy, and we are learning a lot from each other. But clearly, as I suspect many of our talks end, there is still a long way to go, a lot that we don't understand, and a lot that we need to do better to reduce the toxicity of our treatment and to improve how effective it is. So I'm going to pause there. I can see the question box has already ticked up, and I will stop sharing and allow Nick to take over on the Q&A. Many thanks.
Thanks very much, Daniel. We've got 9 minutes, so if you can think about that in your phrasing your answers. I'm going to give you a bunch of questions actually to kick off with. 3 similar ones or related to stem cell transplant. Does anyone know if BuMel or tandem transplant is better? So that's efficacy. And then on side effects, how much more difficult on the child is tandem compared to BuMel? Are there a lot more complications and long-term effects? And then similarly, are the long-term late effects of doing tandem stem cell transplant known? And ultimately, does tandem stem cell transplant increase toxicity? So if you could just talk to those.
Yeah, so those are a great question. So I think the answer as to whether we know whether BuMel is better than tandem or not is no, we don't know yet. So that is the question that's being asked in the current COG high-risk study, which is going to compare North American tandem versus BuMel, and will give us an answer to that question. In terms of toxicities, it's challenging because I think one of the ways that the toxicities are reported in clinical trials is to say what was the worst toxicity that a patient got. And so most of the data from the study suggests that the tandem, the 2, is not more toxic than the 1, because the worst toxicity that the patients got is the same either if you got 1 or if you got 2. But clearly that doesn't actually reflect patient experience, which is that if you get on well during the first one and then get on well again in the second one, that is a worse experience for you than not getting on well twice, even if that's not reflected in the data. So I think we know that having 2 is going to be harder than having 1. And that's why I think many of us were kind of surprised and a little bit frustrated that actually it showed that it was better, because ideally we'd want to think about reducing treatment rather than increasing it. So I think that is something that we need to explore further. And definitely there is a challenge with the tandem, which is that if patients become unwell during the first one, that might compromise their ability to get the second one, and that can be a complication. And then in terms of late effects, we know that unfortunately all of the treatment we give, and especially the high-dose chemotherapy, does have very profound risks of both short-term toxicity and long-term toxicity. It's not, it's not a minor treatment. It's really very, very intensive. I think specifically the late effects of the tandem, we don't 100% know because we've only relatively recently started doing the tandem. But I think we know what the late effects are likely to be. And so I think it's relatively unlikely that there will be big surprises in the late effects. I think we already know, unfortunately, what to expect, and that primarily those late effects are going to be in terms of compromised fertility and potential organ toxicity down the line.
Quick one here. Why has COG never explored rapid COGEC?
It's a good question. I mean, honestly, I don't know the precise answer to that. I think the challenge of rapid COGEC is that it requires a very different mindset into how all of your induction chemotherapy is organized, because as I mentioned, it's very rapid, very intensive, chemo every 10 days, no stopping. And it then means that you can't harvest your stem cells until the end of treatment. You can't do your surgery until the end of treatment. And the way that COG protocols have always been developed is to allow harvesting of stem cells much earlier, to do surgery in the middle of induction. So I think there's just not really been an appetite for changing the way that everything is done in induction to test it. I guess if we get to the point in the future study of something showing that rapid COGEC is dramatically better than something else, then maybe COG will have to reconsider. But I think it's unlikely that we will get to that point of showing that one is dramatically better than the other. So I think it's just going to come down to kind of preference and how things are organized.
So here's an interesting question, which I'm sure you could spend the next 5 minutes on, but we'll try to do it quicker than that. Is SIOPEN, and I guess for that matter COG, willing to investigate the integration of further maintenance therapies, i.e. DFMO, vaccine or other targeted, after the main protocol that you described?
Yeah, so it's a great question as well, and something that I personally am particularly interested in. I think the short answer is yes. The long answer is it depends. So I think the challenge is really how we design a study to ask and then answer a question definitively. I think both of those groups, I think, would be concerned about adding something to treatment without either knowing that it helped or without being able to test whether it helped. So probably that means a randomized study. And the challenge of a randomized study is then we need to compare something new treatment after immunotherapy. So it will be a challenging randomization. I don't know for certain, but I really hope that down the line we will have a study of the vaccine coming. And I would love to see a randomized study of the DFMO question so that we knew definitively whether it helped or not. So I think both groups are interested in this idea, but are still trying to work out how it would work in practice, how we could actually have a study that asked and answered a question.
Do the two groups still recommend high-dose chemotherapy for chemo-refractory children?
Yeah, I mean, this again is all of these are great questions. A very challenging question that we could talk about for a long time, and maybe I'll take to the Q&A at the end. I think one of the differences in approach between SIOPEN and COG is that in SIOPEN, you have to have a very good response to your initial chemotherapy to be allowed to carry on study and to have high-dose chemotherapy on study. Whereas in the COG, you can carry on study and have high-dose chemotherapy even if your disease has not responded at all to induction chemotherapy and you still have stable disease. Now, I think most of us feel that if the disease has not responded to induction chemotherapy very well, we should do something else, and probably we would do something in North America with chemotherapy and antibody to try and get better control of the disease before then going on to high-dose chemotherapy. But I think, honestly, we don't have great data to prove that that is the right thing to do. The important thing, I think, is that from the information from the most recent high-risk study, the tandem study, it showed that tandem high-dose chemotherapy was better than single, but it also showed that tandem was better than single regardless of how well your disease had responded at the beginning. So if you had a complete response to induction chemotherapy, you did better if you had tandem than if you had single. But even if you only had stable disease after induction chemotherapy, you still did better if you got tandem than if you got single, even if overall you didn't do as well as if you'd had complete response. So that suggests that there's still benefit to the high-dose chemotherapy, even if the disease is not under perfect control after induction chemo.
So we've got literally 2 more minutes. How would you know if your child's tumour was TERT or ALT positive? 2 things you mentioned.
Yeah, so I think at the moment, you probably wouldn't, and we as clinicians probably wouldn't, because it's not something we're testing for routinely, and it's not something for routinely because honestly we don't know what to do with the answer. We don't have any information. I think down the line we will get to the point where tumor, and it's quite likely at that point that we would begin to pick up that sort of abnormality. But again, the challenge at the moment is we don't have good therapies for it. So I think it's one of the things that is coming for the future, but not something that is ready for the prime time at the moment.
So with that, we're going to have to leave this session here, but hopefully we can get to some of the other questions that we weren't able to answer when we go to the final Q&A. Thank you, Dr. Morgenstern, for taking us through that. And if everybody wishes now to go back to the agenda page, the next session will be on COG and NANT relapse strategy and trials, which is starting in 1 minute. So thanks for joining us, and see you all again soon.